Our main learning objectives are to describe the different HIV prevention strategies that are available today, to describe in detail pre-exposure prophylaxis and post-exposure prophylaxis in the clinical setting, and also to provide patient education on the effectiveness and the appropriate use of PrEP and PEP in the clinical setting. Now we know that treatment is an important tool as prevention. So U is equal to U. But what does it mean in the context of HIV? So basically, when we say that U is equal to U, we imply that if someone has an undetectable viral load, then that person is untransmissible. That means that person will not transmit HIV to his partner. So U is undetectable equals U untransmissible. And there are very many studies, very robust evidence to support this theory. And if people take their antiretroviral therapy as prescribed, highly adherent, do not miss any doses, then they can achieve an undetectable viral load. And there's no risk of sexually transmitting the virus to an HIV-infected partner. We can safely say that based on the robust evidence that has been presented. And if you need to know more information about U is equal to U, because it's a very important strategy, it minimizes stigma and also helps HIV-positive individuals develop normal sexual relations with others, because previously having HIV stigmatized these individuals, and they always felt that they were at risk of transmitting HIV to a susceptible partner. But by taking their medication as prescribed and having an undetectable viral load, it implies that they are untransmissible. And if you need to obtain further resources, they are available at ASHM, and if you click on this hyperlink, it will take you to the important resources. So what are the prevention strategies that are available now for individuals who want to protect themselves against HIV? We've got TASP or TASP, which is treatment as prevention. It's the use of an antiretroviral agent by an HIV-positive person to prevent ongoing transmission on the basis of U is equal to U. Then you've got pre-exposure prophylaxis. So it's the same antiretrovirals that are used in the treatment of HIV. They're used by an HIV-negative person before he actually places himself at risk to acquiring HIV. And this actually reduces the risk of acquisition of HIV. So this is a prevention strategy that a person takes before a high-risk exposure. Post-exposure prophylaxis is the use of an antiretroviral agent, which is used in the treatment of an HIV-positive person. This antiretroviral agent is used by an HIV-negative person after a high-risk episode to reduce acquisition, but it's done within 72 hours of the risk of exposure. So let's talk now about pre-exposure prophylaxis, or popularly known as PrEP. Pre-exposure prophylaxis involves the use of antiretroviral drugs, that is, the same drugs that are used in the treatment of HIV, by HIV uninfected individuals to reduce their risk of acquiring HIV during high-risk episodes. So we know that it's effective in preventing sexual transmission of HIV in high-risk groups. After a period of clinical trials, this drug was listed on the PBS in April 2018, where individuals who have Medicare are able to access pre-exposure prophylaxis on the government subsidy on the PBS. Previously, Truvada has the most evidence base, but now we are looking at generic equivalents. Basically, tenofovir disoproxil with emtricitabine. Truvada is no longer on the PBS. However, Truvada's generics are easily available and are available on the PBS. So how do we know that PrEP actually works? So we're talking about the optimal use or consistent use of tenofovir disoproxil with emtricitabine. That means taking PrEP daily or at least 4 times per week. So when we look at men who have sex with men, we know that if they take their medication, the PrEP daily or at least 4 times per week, the effective estimate is 99%. And this again is supported by robust studies. In heterosexual men and women, the same effective estimate is 99%. For individuals who inject drugs or people who inject drugs, the effectiveness estimate is 74 to 84%. And this is due to the needle syringe program, but also individuals may still be sharing needles or sharing receptacles. Okay? So the risk of acquiring HIV despite the use of PrEP is slightly higher in individuals who inject drugs. Okay? But if you need to know more information about the estimates, this is available at this hyperlink. But based on the pharmacokinetics of PrEP, we know that adherence is the key determinant of the effectiveness of PrEP. Okay, so if someone takes a medication every day as prescribed, then we get the effectiveness estimate to be about 99%. If they take 4 doses per week, so that's often referred to as T's and S's, so Tuesdays and Thursdays and Saturdays and Sundays, there's a 96% effectiveness estimate. But if they take 2 doses per week, then that effectiveness estimate is reduced to 76%. But we know that PrEP actually works best when it's combined with other HIV prevention strategies to have a synergistic effect. Okay? So examples from the Partners PrEP study, where a number of HIV prevention services were included in a package, including risk reduction counseling, talking to them about the importance of condom use, testing for HIV regularly, U is equal to U, treatment of sexually transmitted infections as they happen through more frequent testing, and then including that with PrEP helped to maximally reduce the HIV risk. And you can see from this study, from this graph, how easily this can be achieved if used with other HIV prevention strategies. Now, when we're prescribing PrEP, we have multiple clinical tools to help us. ASHRM has got a decision-making in PrEP guideline, and they also have PrEP guidelines. So you could easily access this on the ASHRM website. But basically, when you're prescribing PrEP, there are 5 golden rules to follow. You determine their behavioral suitability, determine their clinical suitability. Then you look at other testing strategies like the hepatitis A and B, hepatitis C. Then you prescribe PrEP as suggested in the guideline, and then you monitor these patients on an ongoing basis to determine their ongoing need for PrEP. Okay? But PrEP is actually listed as a Schedule 85 drug. You do not need specific training for PrEP prescribing. Any general practitioner can prescribe PrEP. All you need to do is follow these 5 steps. So if you familiarize yourself with these 5 steps, you should have no difficulty in prescribing PrEP. Okay, so the first thing is behavioral suitability. If an individual comes to you and says to you that they want to go on PrEP, often these individuals have already researched their need for PrEP. So when they're coming to you, they're usually asking you for PrEP. And very rarely do you not provide the PrEP unless they don't meet other criteria. But then you may get an individual who's unsure whether to start PrEP, and then you have to discuss their risk with them. Okay? Patients requesting PrEP, you still discuss their risk. But patients who are unsure whether to start PrEP, they're ambivalent and they're not sure whether they actually need PrEP or not. So by discussing their risk and discussing the side effect profile, etc., you can actually give the patient enough information to determine whether they would like to continue, whether they'd like to continue their request for PrEP. And then also in your consultation, you may find that someone has got recurrent episodes of anorectal gonorrhea. That suggests that you identify this person or this individual as needing PrEP during their consult. Okay, so again, this little ashram tool will help determine whether this person's behavior suggests that they need PrEP. However, if someone requests PrEP, you proceed directly to step 2, where step 2 is determining their clinical suitability. Okay, so you have to make sure that they're HIV negative, and you also have to determine when was their recent HIV risk exposure. Because if they've had sex in the last 6 weeks, then we can't really say for sure that they're going to be HIV negative. Okay, so you have to confirm that they're HIV negative. Lots of clinicians nowadays are actually starting PrEP before the HIV antibody test becomes available. But remember, if you're starting someone on PrEP and they are in the window period for HIV, then you can start PrEP, but make sure that you have all the contact details of that person, that the turnaround time for the HIV antibody test is quick, so that should the person have already be HIV positive, you are able to contact the person and get them to stop PrEP. Now, because there is a risk of PrEP medication, the tenofovir disoproxil, having an undesirable effect on the kidney, someone's baseline renal function should be greater than 60 moles per minute. So that makes someone who's HIV negative with a normal renal function clinically suitable for PrEP. And then in terms of other testing, what other tests do we do? We know that we will do an STI screen, and that includes an oropharyngeal swab for chlamydia and gonorrhea. We do a urine test for chlamydia and gonorrhea, and we also do an anorectal swab for chlamydia and gonorrhea. We also look for other blood-borne viruses like hepatitis A, hepatitis B, and hepatitis C. We know that hepatitis A and B have vaccines against them, so these are vaccine-preventable conditions. And so by determining the hepatitis A and B status, we can offer vaccination as needed. But again, these guidelines are available at the Ashram website. So this section outlines testing recommendations for certain populations and certain situations. Now, when we're prescribing PrEP, we have to determine if the patient has ongoing risk or episodic risks or pre-planned risks, because that tells us whether they need daily PrEP or whether they could take their PrEP on demand. Now, I'll come to on-demand PrEP a bit later, but basically on-demand PrEP is only suitable for men who are born men and who have sex with men and whose HIV risk is from anal sex rather than injecting drug use, based on robust evidence in the literature. Okay? And basically, it's taking the PrEP on demand, which I'll come to later, but basically it's tenofovir disoproxil with emtricitabine taken in a short, sharp burst, where you take 2 tablets at least 2 hours before sex, but up to 24 hours. Then you take 1 pill if you have sex 24 hours later after the first 2 pills, and then 1 pill 48 hours after the first dose. Okay? And then ongoing monitoring. Ongoing monitoring is absolutely essential, because we need to determine if this person remains HIV negative. We also need to determine the side effects of the tenofovir disoproxil with the emtricitabine. Is their renal function deteriorating, or are they having clinical side effects? We need to check their urine for leakage of protein and also for Fanconi syndrome. We also need to make sure that they've been vaccinated against vaccine-preventable conditions. Annually, they need a hepatitis C serology. Okay, so basically, at baseline, we do an EGFR, and we repeat it at 3 months, and then thereafter, we could do it every 6 months. We need to do a urine protein creatinine ratio because it is a leakage of protein that we are concerned about. And in women, because they're having condomless vaginal sex, they're at increased risk of pregnancy. So pregnancy tests should be done at each visit as well. And we must provide patient education. We must discuss how PrEP works, how you should be taking it, what to do if you miss doses, and the importance of continued condom use. Because condoms not only protect against HIV, but also protect against STIs, whereas PrEP only protects against HIV. And basically, we've got on-demand PrEP, which I've just spoken about earlier. This option is for exposure only for short periods of time. So that means usually someone is not having sex regularly, usually less than twice a week, or only if they're traveling, or very, very irregularly. And this data is this data on on-demand PrEP. They're only available for men who are born men and who are MSN and transgender women. Okay, and they're based on a single randomized placebo-controlled trial. There are other studies happening, but basically the IPAGAY and its open-label study, the IPAGAY OLE study, looked at on-demand PrEP. That is, they looked at the efficacy of an on-demand regimen comprising 2 pills of tenofovir disoproxil with FTC, which is called PrEP, and they compared that with placebo, taken 2 to 24 hours before potential exposure to HIV. And if someone is sexually active following their taking the medication, then what they need to do is to take 1 pill immediately 24 hours after the first dose, and another tablet 48 hours after the first dose. So it's not after sexual activity, but rather after the first 2 pills were taken. If sex resumed within a week, then basically a single rather than a double dose before sex is recommended. If sexual activity resumed a week later, then the 2-1-1 schedule, the 2 tablets 2 to 24 hours before sexual activity, then 1 24 hours later and another 24 hours later will pertain. If you are confused and not sure, then the 2-1-1 scheduling is fine. The incidence of HIV was high in the placebo group, and a risk reduction of 86% was reported in the randomized and open label phases. So basically, we know that on-demand PrEP works, but it needs to be taken correctly. And if sex occurs within a week of the last tablet, then you can just take 1 tablet and then another and another. So 1-1-1. Or if sex occurred if sex occurred 1 week after the last sexual encounter, then you need to use the loading dose schedule of 2-1-1. So basically, the on-demand PrEP regimen is suitable only for MSM who have a preference for this regimen. Because some individuals say to you, no, I don't like to take on-demand PrEP. I get used to taking it daily as prescribed, and so I don't really want to change to on-demand PrEP because I may forget. And additionally, it's only for men who have at-risk sex less than twice per week. So if you're having sex more than twice a week, then really you'd be taking too many. So basically, it's reserved for individuals who are having sex less than twice per week. Then it must be for individuals who can predict when they're going to have sex, because there needs to be a minimum interval of 2 hours from taking PrEP to having sex. So it's not for someone who's just going to take PrEP and then going to have sex later. There has to be a minimum interval of 2 hours and a maximum interval of 24 hours. Okay? Now, there's no clear evidence of any reduced side effects, but it may reduce the risk of renal toxicity. So individuals who are not tolerating PrEP because of their renal function deteriorating, that means they have more than a 25% reduction in their renal risk. Okay, so basically two tablets 2 to 24 hours before you're sexually active. If you are sexually active, you take a tablet 24 hours after the first dose and another one 24 hours after the second dose. You need to have 48 hours of tablets on board since your last sexual activity for PrEP to be effective. This is looking at second PrEP. That means if you have sex and it's less than 7 days since your last sexual encounter, then you just need to do 1-1-1. But if you have had sex after 7 days, then you'll have to go back to the 2-1-1 regimen. Okay? There are newer PrEP approaches which have been discussed, like topical PrEP, especially in women, and long injectable PrEP regimens like using cabotegravir. There's a lot of information at the moment. They're not TGA approved yet for PrEP, so we're not discussing that today. Okay, so that was pre-exposure prophylaxis, looking at an HIV prevention strategy before you placed at risk for HIV. Now, this is post-exposure prophylaxis, where an individual is has placed themselves at risk for HIV, and it's within 72 hours of the sexual encounter. So that's called PEP, or post-exposure prophylaxis. So basically, it's the use of the antiretroviral drugs after exposure to reduce the likelihood of HIV infection. Now, we've got no randomized controlled trial to actually provide robust evidence like we have in PrEP, because that would be unethical. So basically, all the information we provide is based on animal data, in case control studies, and then occupational exposure and mother-to-child transmission prevention data. Okay? But it's a 28-day course of taking PEP less than 72 hours since the sexual exposure, but preferably as soon as possible. So if someone comes to you within 24 hours of the sexual exposure, don't wait for 72 hours before starting the treatment. It's not on the government subsidy, and it's only available from NPEP services. The main NPEP service is in Victoria is through the Alfred Hospital, but in other states, they're mainly through tertiary hospitals. Okay? But basically, you need to actually start the PEP as soon as possible. Okay? And PrEP guidelines advise a process for rapid start of PrEP in case of recent exposure, which is essentially NPEP. So if somebody comes to you and they've had a high-risk exposure, if you cannot get to an NPEP service, you can actually start PrEP, which is the same drug as NPEP, tenofovir disoproxil plus emtricitabine, in an effort to start PEP. Okay? So basically the PEP guidelines are national guidelines on non-occupational exposure to HIV, and each of the states and territories have their own guidelines. So you need to refer to their local guidelines. But basically the drug that's used for PrEP is the same drug that's used for PEP. Tenofovir disoproxil plus emtricitabine. And what are the common presentations for NPEP? Usually men who have sex with men, either they have had anal sex and they were receiving anal sex, or they were giving anal sex. So insertive anal sex is where someone's penis is in, that person in front of you, their penis is in someone's bottom. Or receptive anal sex, they were receiving anal sex. Then in heterosexuals, it's vaginal sex. Could also happen in the setting of sexual assault, or people who inject drugs. In a needle stick injury, example like walking through the park and stepping on a needle. And then, of course, in other custodial settings, or in trauma, or through broken skin exposure. So what may increase the risk of HIV transmission? A high plasma HIV viral load. We know that U is equal to U. So if someone is undetectable, they are untransmissible. But if they've got a very high plasma HIV viral load, there's a very high risk of transmitting HIV. Because there are large amounts of circulating HIV, and then that can penetrate and enter the bloodstream. Then if you have an STI, there is strong evidence to suggest that sexually transmitted infections, because they are an inflammatory process, increase the risk of transmitting HIV because of the presence of inflammatory cells at the site of inoculation. Okay? So if someone has got an STI, there's a high risk of co-transmission with HIV, as seen in our syphilis cases. If someone has got a large breach in their mucosal barrier, example, herpes simplex ulceration or a syphilitic chancre, then it is a portal of entry for the HIV virus. Sometimes penetrating percutaneous injuries with a hollow bore needle or through intravenous transmission or intraarterial injection. And then, of course, there's the theoretical risk of not being circumcised, where genital secretions accumulate under the foreskin and get absorbed through the eyelet of Langerhans. So basically, if you're looking for any clinical tools, again, if you go to the ASHRM PEP guidelines, this will provide some good evidence. So when we prescribe PEP, the essential steps are to assess the risk, like we do in prescribing PrEP. Then we also do immediate management and follow-up, so we mustn't delay because we've only got 72 hours in which to prescribe PEP. And then we actually prescribe the PEP according to the specific guidelines. Okay. So basically, when we assess someone's risk of HIV transmission, the risk of transmission is equal to the risk per exposure, like whether it's insertive anal sex or receptive anal sex, or whether it's related to injecting drugs, and the risk of the source being HIV positive. That means, what are the chances of that person being HIV positive if the source is not known to be HIV positive? So if someone is in your clinic and they say that the source of the person, that means the person they had sex with, they're unsure of their HIV status, then what is the risk of that source being HIV positive? So basically, the nature of the exposure with its risk exposure, like I said, whether it's condomless receptive anal sex or insertive anal sex or vaginal or injecting drug or mucosal barrier, or what is the risk of the source being HIV positive? If the source tells you that they're HIV positive, then we need to find out whether that person is on treatment or not. Because if they're on treatment, then U is equal to U. But if their status is unknown, then we have to look at the prevalence of HIV in that particular population. Okay, so if someone is receiving anal sex and someone ejaculates in your patient's bottom, then the risk of acquiring the estimated risk of HIV transmission or exposure is 1 in 70. If the person was receiving anal sex, but the source withdrew his penis, then the risk is 1 in 155. The risk with shared needles and other injecting equipment is 1 in 125. The risk has lowered because of the needle syringe program. In someone who has insertive anal sex and they're uncircumcised because of accumulation of genital secretions under the foreskin, the risk is 1 in 160. If they're circumcised, it's reduced to 1 over 900, 1 in 900, because there are no genital skin under which the secretions can accumulate. If someone is receiving vaginal intercourse, the risk is 1 in 1,250. And if an insert of vaginal sex is 1 in 2,500. So basically, there is efficient transmission from male to female, but transmission from female to male is less efficient. Okay? Basically, if someone is having condomless receptive or insertive oral sex, the risk is extremely low. Then the needle syringe injury or other sharps exposure is about 1 in 440. And then the risk with mucous membranes or non-intact skin exposure is less than 1 in 1,000. Okay, we know that human bites are extremely low. So these estimates are based on prospective studies, not figures derived from modeling. These estimates do not take into account viral load, which, if undetectable, markedly reduces risk estimates because of U is equal to U. Okay, so if we look at HIV seroprevalence in Australian populations, so it's around about 10%. It's highest in Queensland and in Melbourne, and is reduced in other settings. In metropolitan areas, people who inject drugs have a higher HIV seroprevalence, but all others have a much lower seroprevalence. So this is metropolitan statistical data. Heterosexuals in Australia, they have a very low risk, and especially if they're new blood donors and sexual health clinic attendees, very low risk. Commercial sex workers have a very low risk of HIV. Now, these are women or men who work in legal brothels. So they come to the clinic every 3 months to get a certificate of clean sexual health, bill of sexual health. And overall, the Australian seroprevalence is very, very low. So it's mainly men who have sex with men in various states, and the incidence is about 10%. The seroprevalence is 10%. So basically, what is the immediate management of the individual? You've got to reassure the individual, counsel the person, reduce any anxiety and risk anxiety. Make sure you do the STI screen and make sure that there's no evidence of any bleeding or breach in mucosa which needs medical treatment. Then you do a laboratory assessment which involves doing an STI screen, as well as doing your blood-borne virus serology and including syphilis serology. You'd also do a liver function test and urea and electrolytes for future use of PrEP, and a pregnancy test because this is condomless sex, so there's a high risk of pregnancy, not only from this episode, which will only become evident in 4 weeks if the person is pregnant, but from previous exposures. Okay. So we say do not douche the vagina or rectum after sexual exposure because this may cause breaks in the integrity of the skin and allow a portal of entry for the HIV. After oral exposure, you spit out the blood and the body fluids, you wash the wounds, you irrigate with mucous membranes. Just be very gentle and try to superficially clean the lesions, okay? Again, PEP guidelines are available at that hyperlink. Okay, so what do we need to discuss? We need to explain that person's risk using the profiles I described earlier about receptive anal sex or insertive anal sex, and what the seroprevalence of HIV is in that source. We have to tell them that there's no robust evidence that PEP works, but we know that it works in animal studies and mother-to-child transmission and occupational health settings, and that they need to be highly adherent to treatment over 4 weeks. And we need to talk about other safe practices, sex practices, talking about side effects of the drugs, the risk in pregnancy, and the importance of follow-up testing. Counseling and support are very important because these patients may have a lot of anxiety about their risk of acquiring HIV. Okay. But basically, we should actually provide the PEP early, within 72 hours, because we must not delay it while obtaining information about the source. So if we don't know anything about the source, but this patient is in your office within 72 hours, you've got to actually prescribe the PEP. So you look at the exposure, that means insertive anal sex or receptive anal sex. The exposed person, are they already HIV positive, or what is their risk? And then the source, but don't wait for information about the source before starting treatment. Now, what about which drugs we use? Okay. Now we know, I just want to go through this column here. If the source of the virus, of the viral load is unknown, is unknown or undetectable. So undetectable here, so U is equal to U. So you do not need to use prescribed PEP. So if someone comes to you and says they had sex with someone who is taking, who's already HIV positive, but he's taking his medication properly, and says that he's undetectable, or shown me that his results are he's undetectable, then we do not recommend PEP because of the process of U is equal to U. However, if the source is not on treatment, so he'll have a very high viral load. Someone who's not on treatment will have a very high viral load. Or he is on treatment, but he's not taking his medication properly, or he's got multi-resistant virus, or we do not know what's his viral load, then we've got to use 3 drugs for all types of sex, okay? Except oral sex, which is not recommended because the risk is extremely low, okay? So basically, if the source is HIV positive and does not have an undetectable viral load, then 3 drugs are recommended. Okay? Then this is someone with an unknown HIV status. So we're going to look at the seroprevalence that I've shown on the previous few slides. So what is their risk of exposure? So receptive anal sex with ejaculation is 1 in 700. Withdrawal is 1 in 1,550. So this is based on the seroprevalence of 10% for MSM. So you use only 2 drugs, which is the same drug as PEP, which is tenofovir disoproxil plus emtricitabine. Okay, if they have sharing needles or other injecting equipment, then you calculate it based on the seroprevalence in that population. Okay, if they're receiving anal sex, so uncircumcised, and they are inserting their penis into someone's bottom, the risk is 1 in 1,600, and you use 2 drugs. Okay, if they are circumcised, then that means there's no genital skin, then it's 1 in 9,000. Okay, and you would consider 2 drugs if the source is MSM or say from a high prevalence country where there's HIV. Okay, so basically, if someone is insertive, that means a heterosexual man is inserting his circumcised penis into someone's vagina, and that person may or may not have HIV, you actually do not need to use PEP. Okay, we only really use PEP for insertive anal intercourse if the source is a man who has sex with men, so bisexual men or gay men, or they're from a high prevalence country like Africa, Southeast Asia. Okay? If someone is receiving vaginal sex, the risk is 1 in 1.25 million. Okay? So you don't actually need to use PEP because the risk is so low. Okay? So it's not recommended, and you consider 2 drugs if the source is MSM or from high prevalence country. Insertive vaginal intercourse, so this man is inserting his penis into someone's vagina, the risk is the same. Oral sex, it's not measurable, so we don't use PEP. And for mucous membranes and non-intact skin exposure, so like say if ejaculate gets into the eye, it's not recommended to use PEP if the status is unknown. Okay? And basically, a needle stick injury from a discarded needle in the community, the estimated risk is not measurable and it's not needed. Because the risk of that needle being contaminated with HIV is very low. So basically, these are based on seroprevalence data. So in MSM, the seroprevalence is 10%. In this patient here, with individuals sharing needles and other injecting equipment, it's based on a seroprevalence of about 1%. And then if we look at information based on estimated seroprevalence of 29%, because this person is MSM, right? And then based on estimated seroprevalence of 0.1% in females. with HIV. So the seroprevalence of HIV is 0.1% in the heterosexual community. Okay. So then we look at PEP recommends after occupational exposure to a known HIV source. This is completely different. When we talk about NPEP, we're talking about non-occupational exposure. Okay. So this is needle syringe exchange or other sharp exposure. The estimated risk is 1 in 440. If the person is not on treatment or has an undetectable viral load, then if the person has an undetectable viral load, you consider 2 drugs. If the person is not on treatment or has an unknown viral load, you've got to use 3 drugs. If there is mucous membrane exposure and non-intact skin exposure, the estimated risk is 1 in 1,000, and then again, depending on whether the source is on treatment or not. Okay. If the source has an undetectable viral load, you use 2 drugs. If the person doesn't have an undetectable viral load or has an unknown viral load, you need 3 drugs. So PEP may be recommended if the needle and syringe contain fresh blood and sufficiently penetrated the skin. So in this situation here, if there is fresh blood and it sufficiently penetrated the skin, then you need to consider PEP. And then the 2 drugs that we use, tenofovir, disoproxil with emtricitabine, which is known as Truvada, but then we have generics of Truvada. Or we could use 2 separate drugs, tenofovir 300 milligrams with lamivudine 300 milligrams. This is cheaper than Truvada, but now the generics have made the single-dose tablet cheaper. If you need to use a 3-drug regimen, then you've got to use your 2-drug regimen, which is tenofovir disoproxil and emtricitabine with either dolutegravir or raltegravir or ropivir. Okay? Raltegravir is not usually used because it increases the likelihood of drug-drug interactions and rhabdomyolysis with raltegravir, so where there's breakdown of muscle. Okay? So basically, we're looking at cost. Cost is very, very high. Okay? So if you're using tenofovir with lamivudine, it's about $568. If you're using Truvada, $700, and then it becomes more expensive with the 3-drug regimens. Okay? So that is why we have the NPEP service to provide PEP. The recommendation for the number of antiretrovirals based on an extrapolation benefit conferred by increased numbers of classes of drugs for HIV treatment. So basically, we are using 3 drugs instead of 2 drugs because using 3 drugs like dolutegravir or ropivir or raltegravir and adding that to your 2-drug regimen blocks the entry and replication of the virus or something that provides an extra level of protection compared to just what tenofovir disoproxil and emtricitabine provides. So we know that if we use dolutegravir or raltegravir, they are what we call INSTIs, so the integrase inhibitors, so they prevent the virus from integrating with the host genome, or ropivir, which is an NNRTI, so that acts as a false substrate. So for the reverse transcriptase enzyme. So basically converting the HIV virus from an RNA virus to a DNA virus so that it can integrate into the host genome. So basically 3 drugs provides a greater level of protection because it's acting on a different site compared to the 2-drug regimen. Okay. So if you're giving PEP, everyone has to have an HIV antibody test, okay? Hepatitis B serology because of protection against hepatitis B and also to determine whether someone needs a vaccine. Hepatitis C serology for determination of whether they're hep C antibody hepatitis C exposed. If they have a past history of hepatitis C or they've just got a hepatitis C antibody positive, then you need to do hepatitis C PCR testing. Do you do an STI screen with syphilis testing? We do a liver function and a urine electrolyte, and we also do a pregnancy test in women. And then you can repeat the STI screen in week 2, because if they've the baseline STI screen basically is not for the exposure that occurred within 72 hours, but previous exposures, and then you repeat it at month 3. And week 4 to 6, which mainly 6 weeks, that's the window period for HIV. Then you do the HIV antibody test, the syphilis test, and the baseline test. And in month 3, you do those tests there. Again, that's available at the PEP guidelines. Okay. What else you consider? You consider hepatitis B, because if they've had an exposure and the source is hepatitis B positive or S antigen positive, and this person is non-immune to hepatitis B, you have to consider obtaining immunoglobulins from the nearest emergency department. You do an STI screen, hepatitis C, to eventually go on to hepatitis C treatment. You've got to consider emergency contraception, think about tetanus. And if you work in an NPEP service, you provide the NPEP medication. So if you don't work in an NPEP service, you discuss with the NPEP hotline. Each state has its own NPEP hotline or the local sexual health service, and then immediately start using PrEP if you can't access PEP. Because remember, PrEP and PEP are exactly the same drugs. And you arrange follow-up testing, contact tracing, and support. Okay, so these additional management guidelines and issues are available at the PEP guidelines. So you're going to look at the preventive behaviors of using condoms and other HIV prevention strategies. Then if someone declines PEP, what are their risks? Individuals who come in requesting PEP, but their risk is absolutely negligible. Patients who keep coming in, so repeat representers for NPEP. You got to talk to them about PrEP. Individuals who are on PrEP already, so they don't need PEP, it's exactly the same drug. Then those transitioning from PEP to PrEP, it's exactly the same drug, but they need to transition. Then if they've got renal disease, because if they've got renal function that's less than 60 moles per minute, whilst it's not an issue for NPEP, it is an issue for PrEP. Okay? Then the gender identity and history, because that will determine whether they can use on-demand PrEP or daily PrEP. And individuals who come from high prevalence countries. So that's your PEP hotline, and that's part of the, it's at 1-800-PEP now, but also to contact the local sexual health service. Okay, so let's do a case presentation, because it'll encapsulate all aspects of what we just spoke about. So we've got a 24-year-old man who's gay and recently moved to the city from the rural area. Okay, he's got a past history of a sexually transmitted infection. He's got gonorrhea. He's got casual relationships only, and he meets these casual partners on the internet. His name is Damien, and he's waiting outside your clinic. It's very early in the morning, on a Saturday morning, because he's very, very anxious. He attended a sex on premises venue 2 nights ago where he had condomless sex. And when he spoke with that person in the chat room, he told him on Thursday night at that particular venue is a positive night. So that means the likelihood of you sleeping with someone who's got HIV is very high. And it was suggested that he should go and get access to treatment to prevent HIV. Okay? So what information do you need? What was his sexual exposure? Because that will determine his sexual risk. He says he had condomless receptive anal sex. So he was bottom and someone put their penis into his bottom. And it occurred the night before last, so within 72 hours on the positive night. The contact was unknown to him, but Damien said he was healthy looking. He didn't look like he had HIV. So again, to talk to Damien about not looking at someone and deciding whether they've got HIV or not. Damien has no symptoms to suggest a current STI. He has only been tested for STIs and HIV once once before, about 3 years ago, and at that point he had anorectal gonorrhea. So he last tested for HIV more than 3 years ago. So what is Damien's risk of acquiring HIV? We know that his risk of transmission is based on his risk per exposure. So his risk of having receptive anal sex and the risk of the source being HIV positive. So there's a 10% seroprevalence of HIV in the MSM population, and his risk of exposure is based on the presence of receptive anal intercourse. So someone ejaculated inside his bottom, the risk is 1 in 70. If that person is already HIV positive, if the source is of unknown status and they withdrew from his bottom before he ejaculated, the chance is 1 in 1550. So his risk is anywhere between 1 in 70 and 1 in 1550. Okay. He's already at high risk for HIV because he actually hasn't had a test in the last 3 years. Okay. So basically, we need to talk to him about the importance of testing. So basically, based on just solely on his risk exposure, his exposure lies somewhere between 1 in 70 and 1 in 1550. Because if we look at his previous risk, we found that 1 in 70 is if that person is HIV positive and that person is HIV positive and that person ejaculates in his bottom, and 1 in 1550 if the source is of unknown status and withdraws before ejaculation. So that's the risk of transmission. So would you give him PEP? Yes, because he had condomless receptive anal sex. And would you use 3 drugs versus 2? So we said if someone has condomless receptive anal sex with a known HIV positive partner, and if that person is on treatment and has an undetectable viral load, U is equal to U. But we don't have this information. He has no idea about the source's viral load if he is HIV positive. Then 3 drugs if the source is not on treatment or we don't know what his load is. And we use 2 drugs if the sex is with someone of an unknown partner. What is the potential disadvantage of giving Damien 2 drugs? Damien may actually already be HIV positive, right? And because he last tested more than 3 years ago. And also, if you do not give him 3 drugs and the person that he had sex with has an extremely high viral load, then you're not providing greater levels of protection as you would if you gave 3 drugs compared to 2. You do baseline HIV antibody testing and you consider doing an HIV rapid test. But remember, the HIV rapid test may miss very early HIV seroconversion. So any test that you do for HIV must be coupled with a laboratory evaluation using a 4th generation test. So what tests would you order? You do an HIV 4th generation test, which labs are still doing now. You do syphilis serology as part of STI screening. You do an MSM screen, which involves an oropharyngeal swab for chlamydia and gonorrhea, anorectal swab for chlamydia and gonorrhea PCR. There's no need to do a urethral swab for chlamydia and gonorrhea. You can just merely do a urine test for chlamydia and gonorrhea. And then you'd also do urea and creatinine if you're considering PrEP in the future. You do other bloodborne virus screens because of vaccine-preventable conditions and also to determine if they're already exposed to hepatitis A, B, and C. And which 2-drug NPEP regimen would you choose? You would choose tenofovir disoproxil plus emtricitabine for 28 days, or you'd use tenofovir disoproxil lamivudine for 28 days. Remember, NPEP is not funded by the PBS. It's each state and territory funds its own NPEP, so you need to learn about the local funding within your state. Okay, and more information is available at the ASHRM website. Then other issues you have to discuss with Damien. Does he need is this a aberration or is this going to be continued risk behaviors? Then he'll need treatment for PrEP. You need to ascertain his knowledge about STIs and the importance of screening. He last screened 3 years ago. You've got to work out why. Because maybe he was not sexually active in the last 3 years, or he may have had a long-term partner and they were monogamous. So you need to explore why he didn't get tested more regularly. Then if he talks about zero sorting, that means finding other HIV negative men or other HIV positive men with U is equal to U. We've discussed the risks of that because of the importance of adherence. You need to give information that is culturally appropriate as well. Okay, so Damien's results come back and his HIV test is negative. His syphilis test is negative, but you've already started him on PEP. You're not going to wait for these results, okay? He had a test for gonorrhea. We did a urethral swab because he had discharge coming from his penis. So he needs to be treated for gonorrhea. He also has gonorrhea in his throat and his bottom, so that he needs to be treated for gonorrhea. His hepatitis B antibody is not detected, but he's core antibody positive and his S antigen detected. So that means he has hepatitis B. He's a carrier of hepatitis B. He's also been previously exposed to hepatitis A or has been vaccinated against hepatitis A. He doesn't have hepatitis C, and fortunately he has good renal function of more than 90 moles per minute. Okay, so we're going to treat the gonorrhea that he has at both the throat, anus, and urethra. His S antigen detected, so we need to find out more about his hepatitis B viral load. He's got a very high viral load. His E antigen detected, but not E antibody, so that means he's not immune. His core IgG detected, so usually he's had the infection not in the last 3 months. His ALT is normal, so his liver function is normal, his platelets are fine. So basically, he's in the immune tolerance phase based on his liver function being normal. What impact he's having hepatitis B has on his NPEP management? None, because taking NPEP for a month does not result in flares of hepatitis B. But if he's on PrEP, then it will, because he cannot use on-demand PrEP. And when should Damien start his PrEP? He should start his PrEP. He should transition immediately from NPEP to PrEP, okay? But basically, this course is not about managing hepatitis B. If you'd like to do chronic Hep B management, then Ashram offers an S100 hepatitis B viral course for those who are interested, okay? What if he decides to complete the PEP but not PrEP? Usually you need to do this in conjunction with a hepatologist who knows about the risk of acute flares in stopping hepatitis B treatment, because we know that tenofovir, emtricitabine, and lamivudine all have activity against hepatitis B, and we're using 2 drugs to treat the hepatitis B and to prevent flares, okay? Stopping daily PrEP in patients with chronic Hep B can be difficult, and therefore you need to include a hepatologist, okay? Basically, you have to use 2 drugs, which is tenofovir disoproxil with FTC or tenofovir disoproxil plus lamivudine. Some countries use tenofovir disoproxil alone for PEP, but we do not do this here, and also because of the risk of causing acute flares in hepatitis B. Okay, then the PrEP follow-up, it's important to follow the Ashram guidelines. Every 3 months you get some testing done, which includes definitely an HIV antibody test, STI screen, and you assess the adherence, the side effects. And then after 3 months, when you've done their first, repeated all their tests, then 6 monthly you could do a renal function and a urine test. But every 3 months, someone who's on PrEP needs a hepatitis screen if they haven't had one, and they also need to have an HIV antibody test and STI screen. Okay, if they are non-immune to hepatitis A and B, they need to be offered vaccination. At least every 12 months, they need to be tested for hepatitis C because of the risk of sexual transmission of hepatitis C, especially in MSM and people who inject drugs. And then every 3 months, get their renal function done, including the protein creatinine ratio. Not necessarily the albumin creatinine ratio, but it's mainly the protein creatinine ratio because of Fanconi syndrome. If the eGFR is declining steadily, but it's still at or above 60 moles per minute, then you should consult with a renal specialist because this patient could be offered on-demand PrEP. Okay, but also we need to determine what are the reasons for their declining renal function. Okay. So anyone with acute increase in their creatinine should be referred to the specialist.